This is Raeshel Clifford performing a comprehensive diabetic foot exam. Patient is a 43-year-old male who's diagnosed with type 2 diabetes approximately 3 years ago. He's on metformin and Tridenta. His medical manager is diabetes as per his family doctor. Last hemoglobin A1C was 6.9 and last fasting blood glucose was 118. He has no known drug allergies. Patient is consented for a comprehensive diabetic foot exam to be video recorded and uploaded to the site for grading purposes. Patient denies numbness and tingling. He has no cramping or aching with walking and no signs of neuroclaudication. First thing we're going to do is inspect for any digital deformities. We're going to look for hammer toes, curved toes, any plantar flex, metatarsal heads. No signs of that. We're also going to check for equinus and see if he has a tight heel cord, see if we can push the foot up past 90 degrees, able to do that easily on both sides. Next thing we're going to check for is Charcot deformity, where they have lack of an arch and the foot actually can collapse in and break. This is typically painless due to neuropathy, and there are no signs of that either. No amputations, no ulcers, some dryness about both heels, and but no calluses, no cracking, checking between the toes, checking the toenails. On this one toe here on the right foot, on the third flange, the toenail is very thickened and there is some redness around that, possibly concerning for tinea, and may need to be on some medications for that. You're going to check temperatures on the bottom of both feet and tops of both feet, and that's equal. Next going to check for pulses. Good pulses on both sides of tibia and antilis. There's no swelling, no varicose veins. Next I'm going to check for capillary refill. 3 seconds is good. Next, going to check for sensation with monofilament testing. I'm going to have the patient close their eyes, and I want them to say now when they can feel me touching them.
No. 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 No.
Going to repeat that on the right foot.
No. 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 No.
Good. Oops, I'm going to check the tops of the feet. I'm sorry. Close your eyes one more time.
No. No.
Good. Patients are unable to feel that. They typically have lost their protective sensation, and this puts them at greater risk for developing wounds and ulcers. Also going to check vibratory sensation with the tuning fork. We're going to do this on both toes. Going to this here. Let me know when you stop feeling the vibration.
No.
Okay. And then we're going to repeat that. The right foot.
No.
Good. Next, we're going to do sharp and dull testing. Going to have the patient close their eyes again. This is sharp, and this is dull. Okay, and which one am I doing now?
Sharp.
And which one am I doing now?
Dull.
I'm going to repeat the same thing. This is sharp, and this is dull. And which one am I doing now?
Sharp.
Which one am I doing now?
Dull.
Good. Next, we're going to check for reflexes. And check the ankle reflex. There we go. And here. I'm sorry. There we go. Good. Loss of ankle reflex is also often a sign of advanced peripheral neuropathy. Patients with no signs of diabetic neuropathy need yearly exams, and so we'll need another exam in a year from now. Patients with any signs of neuropathy will need an exam in 6 months. Patients with poor circulation and signs of neuropathy will need quarterly exams, and patients with active problems bi-monthly and possibly more often than that. Patients need to be encouraged to do nightly foot exams. And if they have any signs of neuropathy, you can actually give them a monofilament so they can test their feet themselves each night. Not because the testing will change with time, but because it encourages them to actually be checking their feet on a nightly basis. This completes my diabetic foot exam for Raeshel Clifford. Thank you very much.